Emergency management for shoulder dystocia. For assessment, assess the woman to be transferred to the nearest consultant unit or hospital for delivery. Assess the client's ability to follow instruction. Next procedure is gather all items you will need for the internal examination. First, ma'am, I will gather all items needed for the procedure for easy accessibility. Okay, ma'am. Next procedure is identify the client, introduce yourself, and explain the procedure for internal examination. Ma'am, good day. I'm Ricardo Bautista Jr. I will be your nurse for today, and I will do internal examination by inserting my glove fingers to assess the progress of your labor. For rationale is to obtain client's cooperation and work simultaneously. Next procedure, position the client on the examination table. Three positions are employed for internal examination, which are dorsal recumbent, Sims position, and the knee chest position. Ma'am, you will be positioned on the examination table to assess the progress of your labor. For rationale, the aforementioned positions are made best so as to expose the gynecologic area to be examined. Position depends on client's capability and examiner's preferred position. The internal examination position, the dorsal recumbent, the knee chest position, and the Sims position. Drape the client, expose only the gynecological area. Ma'am, I will put the drape on you for your privacy, and I will just expose the part that I only need to assess. Okay. For rationale, always respect the client's modesty and to provide privacy. Wash hands and put on examination gloves. Ma'am, I will do hand washing and put on examination gloves to assess the progress of your labor. For rationale, to protect the healthcare provider from contracting gynecological diseases caused by highly infective organisms. During the emergency delivery, notify assistant or backup to enlist other appropriate healthcare providers, including those healthcare providers skilled in neonatal resuscitation. And ma'am, I will notify other healthcare providers to assist or back me up during the emergency delivery and neonatal resuscitation. Rationale, when shoulder dystocia is suspected, the nurse can be prepared to assist staying calm and calling for added assistance with healthcare providers. Next procedure, perform acrobatic maneuver by helping the client to move to a lithotomy position, supine with buttocks at edge of the bed, lower head of bed if elevated, hyperflex both legs, and I will instruct the mother to grasp her posterior thigh and flex them against her abdomen. Macroboids maneuver straightens sacrum and decreases angle of inclined symphysis pubis and dislodges the impacted shoulder. Shoulder dystocia is often resolved by this maneuver alone. Mazzanti maneuver is done by applying pressure on the suprapubic region is done to dislodge anterior shoulder and simultaneously instructing the client to bear down while I apply suprapubic pressure downward with palm or first 30 seconds of continuous pressure. Fundal pressure alone is to be avoided because of the potential neurological complications. Mazzanti maneuver, this is done by another healthcare practitioner. Vaginal approach, Rubin's maneuver or reverse wood screw maneuver, is done by adduction of the anterior shoulder by pressure applied to the posterior aspect of the shoulder. The shoulder is pushed towards the chest or pressure is applied to the scapula of the anterior shoulder. This maneuver attempt to position the shoulders to utilize the smallest possible diameter of the fetus through the largest diameter of the woman. Rotation of the posterior shoulder with screw maneuver is done by applying pressure to the anterior aspect of the posterior shoulder, and an attempt is made to rotate the posterior shoulder to the anterior position. For rationale, Wood's maneuver is a screw-like maneuver. Success of this maneuver allows easy delivery of that shoulder once past the symphysis pubis. Delivering the posterior arm is done by applying pressure intravaginally at the antecubital fossa, which causes fetal arm to flex, and I will grasp it and sweep across the chest and towards the opposite side of the fetal face. The rationale, this may lead to humeral fracture if it is not done properly, which does not cause permanent neurological damage. Next is the episiotomy. Nurses cannot perform episiotomy and should be done by the obstetrician. May be delayed until after pressure and McRoberts effect. It increases room to work for rotational maneuvers. Roll over to all fours position. Gaskin maneuver is done by assisting the client to roll onto hands and knees, and I will apply downward traction to deliver the posterior shoulder that can be repeated until the shoulder of the fetus is delivered. The rationale is this is believed to increase pelvic size and make use of the force of gravity. Baby's out 4:30 p.m. Healthy baby boy. After the delivery, I will assess the baby's motor reflex and check for fractured clavicle or humerus for possible injury. A complete symmetric motor response usually indicates no brachial plexus injury, which is the most common serious resulting in injury. If an injury occurred, be prepared to discuss the possible outcomes with the parents after the pediatrician has spoken with them. 80% of these injuries resolve and cause no permanent damage with appropriate treatment. After delivery of the placenta, I will check for its cotyledons. If it is complete, I will assess the perineum and the vagina for lacerations. For rationale, this is the greatest risk to the mother from a shoulder dystocia. The hemorrhage is usually related to uterine atony or vaginal or cervical lacerations. Next procedure, I will remove my gloves after I clean the instrument and will wash my hands after. The rationale to limit the transfer of microorganisms is document the procedure, and the rationale is to provide accurate data in the care of client.